Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Sydney Bonnick. She is an internal medicine physician, and her Kevin MD article is titled Hippocrates is Crying. Sydney, welcome to the show.
Thank you so much for having me. I really appreciate the opportunity.
We'll get into your article in a little bit. First off, just briefly share your story and journey to where you are today.
I am an internist, as you've already mentioned, and I actually knew when I was 12 years old that I wanted to be a physician. Now, I realize deciding to be a physician at a relatively young age is not particularly unique, but I also knew that I wanted to attend the University of Texas Southwestern Medical School in Dallas, and at the end of my residency training, become a board-certified internist. And in fact, when I was 12, I actually wrote to Southwestern to ask for their catalog, which they sent me. And I can't tell you the number of hours I spent turning the pages, looking at the photographs, reading the course titles, and imagining myself there. And fortunately, I was able to attend Southwestern. And at the end of my residency training, I did become a board-certified internist. And I practiced general internal medicine for quite a few years. And then an orthopedic surgeon with whom I frequently worked began to refer to me women that he saw with postmenopausal osteoporosis and a variety of different kinds of fractures. Additionally, he had arranged for the hospital where we both worked to purchase one of the very first clinically available bone densitometers and asked if I would be interested in learning how to utilize it. And one thing led to another. We found ourselves doing clinical research in the prevention and treatment of postmenopausal osteoporosis. That led to the publication of quite a few articles reporting research study results, which then led to invitations to sit on a variety of consultant boards, to lecture. And finally, I like to think, because of the expertise that we developed in bone densitometry, I was asked to be one of the 6 founding members of what was then called the Society for Clinical Densitometry and is now known as the International Society for Clinical Densitometry. But at heart, I have always remained a general internist.
We have a lot of medical students who listen to this podcast. I'm a general internist as well, but from a perspective, tell these medical students reasons why they may want to consider general internal medicine as a career.
I always wanted to be able to help my patients, no matter what was wrong with them. And of course, where that starts is in finding out what's wrong with them, what their complaints are, what disease has caused their complaints. And so as an internist, I am very much a diagnostician. And I may not be the one who cures their disease, but I wanted to be the one to find out what their disease was. And I think that need still profoundly exists in medicine today. We have a lot of subspecialists. In fact, when I became an internist, internal medicine was a specialty. And the cardiologist and the endocrinologist, those were subspecialties of internal medicine. I tend to think that people now consider internal medicine a primary care physician, and all of those other things are the specialists. Indeed, I think the good internist is a specialist in the diagnosis of adult disease. And that is something we sorely need today.
All right, let's transition into your Kevin MD article titled Hippocrates is Crying. Now, for those of you who get a chance to read that article and story, just share it with my audience today.
Well, the article is about essentially my sister's last week in the hospital, the last week of her life. And after she died, in addition to grieving, I found myself becoming increasingly angry with each passing day, to the point that the anger was almost incapacitating. I just kept thinking I have to do something, but I didn't know what. And then one morning, about 3 a.m., I realized I could write about what had happened during that hospitalization. I had written before, had things published. I knew how to do that. And I thought perhaps if I could write about it, tell my colleagues what had happened, I could help prevent it from happening ever again. So I began to write the very next day. And there were several versions at first. And each time I reread them, the anger was just palpable. And I thought, this is going to be too painful for anyone to ever read, let alone anyone to ever publish. And so I stopped for a while and then started to write again. And as I did so, I realized that it wasn't my anger that was important. What was important was why I was angry. And at the same time, as horrible as it is to lose someone you love, what I wanted my colleagues to know was not that my sister had died, but why she died. And so I began to write again with those things in mind. Now, recounting the conversations and events of that week was not difficult because those things were burned into my brain. And the initial conversations I had, particularly with one of the physicians, was angry. And I couldn't remove the anger from my words because I wanted to repeat that conversation exactly as it happened. And I was angry. When I arrived at the hospital, I didn't know anything had gone wrong the night before. My sister had gone into the hospital because of epigastric and abdominal pain. She had a history of stage 4 breast cancer, but that was not the issue. She was having abdominal pain. And they had attempted to place an NG tube in her hospital room and could not do so. And so they had decided to place that NG tube under anesthesia. That I knew, but I did not know things had gone so horribly wrong during that procedure. So when I arrived at the hospital the next day, I had a room number for her. And as I rode up in the elevator and looked at the signs in the elevator, I realized that the elevator was taking me to an ICU and that her room number was within that ICU. And at that point, the elevator couldn't move fast enough. And I was numb. And I remember going through those double doors into the ICU, ignoring the visiting hour sign, and going back to her room and seeing her lying in that ICU bed with an endotracheal tube on a ventilator, a cardiac monitor showing her heartbeat and her blood pressure, numerous IVs running. And she, of course, was not conscious. And there was a young doctor standing at the foot of her bed. I told him my name and that I was her sister and that I was an internist. And by then I was already becoming angry at what had happened to her, although I had no idea what that was at the time. And so I said to him, I said, how do you go for an NG tube and end up in ICU on a ventilator? And then my anger spilled over and I said, other than medical incompetence. And he never looked at me. He never told me his name. He simply stared straight ahead at my sister in the bed. And finally he said, "She has stage 4 breast cancer." And I said, "You don't know that," assuming that he was offering that as an explanation. And I said, "You don't know that." And a brief period of time went by and he simply repeated, "She has stage 4 breast cancer." And I said, "You don't know that." "Yes, she has stage 4 breast cancer, but she has stage 4 because she had metastases in distant lymph nodes, not in any viscera, never in any viscera." And as I looked at her, I saw her abdomen was swollen. And I asked him, I said, "Are you pumping air into her abdomen? Have you even bothered to check the tube placements?" And again, without looking at me, he said, "Her abdomen looked like that when she came up to ICU last night." And I was horrified at his response because it told me that she had looked like that for over 12 hours and no one had ever done anything. And I was livid. And I said to him, "She walked into this hospital asking for help. Look at her now." And he stared at her for the longest time. And then finally he turned on his heel. And as he walked out the door, he said, "I guess we could get an abdominal CT." And I heard him give the nurse the order, although he didn't order it stat. The abdominal CT was done several hours later. After it was done, she was taken for emergency surgery because the CT showed that there was free air in the abdomen. And for a brief period of time, I thought, all right, they can fix this. This is something they will fix. But then I spoke to the surgeon after the surgery was over. The surgeon knew I was a physician, so she knew she didn't have to explain the terminology or soften the results. But she told me what they found was a huge rent in the posterior fundus of the stomach. And that had allowed over 3 liters of fluid, undigested food, bile acid, stomach acid, to spill into her abdominal cavity. And clearly, that is likely why she went into respiratory distress at the conclusion of the insertion of the NG tube under anesthesia. They repaired the tear in the stomach as best they could. They cleaned out all the debris from her abdomen. They had to leave the abdominal incision open because of concerns about infection. But the surgeon told me her electrolytes were in disarray. Her pH was down to 7. And she said, "Frankly, I don't think she'll survive the night." She did survive the night and the next day as well. They corrected her electrolyte disturbances. Her pH climbed back up to 7.3. And 48 hours later, they took her back to surgery to look again to make sure they had cleaned out all the debris and to close the incision, which they did. But she was never able to come off the ventilator. She required pressor agents to support her blood pressure. And while she initially responded to painful stimuli, after about 4 days, she no longer did. And several days later, she died. After all of that, I truly tried to go back and look at those events, not as her sister, but as a physician, to try to make sense of it all. Now, I would be the first to admit that it's impossible for me to totally separate those two things. I am her sister, and I am a physician. But for the life of me, I cannot understand how, when a patient goes into respiratory distress in the immediate aftermath of an invasive procedure under anesthesia, how any physician could so readily attribute that to a pre-existing condition, a condition they had when they walked into that hospital, could give a lucid and complete medical history, were conversant and oriented. They had that pre-existing condition then. How could it possibly be the cause of respiratory distress now? And I could not understand that. Now, my sense was that the young physician that I initially met, that he came to realize what an egregious mistake they had made. And my hope as a physician is that perhaps someone, some patient, will benefit from that in the future. But as her sister, I still continue to grieve for her.
Thank you for sharing that story, and I'm so sorry for your loss.
Thank you.
So sometimes interventional procedures in medicine don't go as expected. If this were to happen again, what would have been the appropriate response from that clinician after realizing an unfortunate event occurred?
You're absolutely correct, of course. Even the most skilled physician performing a procedure can have something go wrong. That is a sad but absolute true reality in clinical medicine. And as I've looked back on this, my anger is not really that something went wrong during that procedure. My anger is because no one even bothered to think about that possibility. That is where I think those physicians failed my sister. Because obviously with a horrendous injury like that, a tear in the stomach that allows all of those things to flow into the abdominal cavity, every second is precious in correcting that if you're going to save that patient's life. But nothing happened for almost 18 hours. And it only happened because one very angry physician's sister let that young man know that things were wrong. And perhaps I simply delayed the inevitable at that point in time. Because if every second is precious, if you're going to save a patient, if you wait 18 hours, the chances of a successful outcome are virtually nil.
Now, after this event happened and you've had time to reflect, did you do anything afterwards? Did you ask for an apology? Were any apologies offered? What happened in the aftermath of this event?
Actually, toward the end of the hospitalization, many of the nurses on that ICU floor, and the nurses were outstanding. The nurses knew what had happened, and they knew I was a physician. We'd had many conversations, and even the critical care specialist said to me at one point that this young physician told her that I had asked, how do you go for an NG tube and end up in ICU on a ventilator? And she said that to me, and I said, I thought that was a reasonable question. And she agreed. They knew how upset I was. And actually, I think the nurses requested that someone from the hospital administration come up and speak with me. And a young woman did. She listened to what I had to say, what events had occurred. She took notes, and she assured me that there would be an investigation into everything that had happened. And I asked, of course, if I would be told the results of that investigation, who they talked with, what they did. And she said, because of privacy concerns, they would not identify anyone or what was done or what was said, but they would let me know the result of the investigation. And what I was told actually some months later was that the hospital had decided no one did anything wrong and the investigation was closed. And that was the end of that.
In your ideal world, what would you have liked the response to the hospital to be?
That is very difficult to say. There were clearly, to me, some egregious decisions made or lack of decisions made. I honestly do not know. I know the young man I spoke with, I feel certain that he realized that he'd made a mistake, or at least an error in judgment. And I know, as a physician who's been practicing more years than I like to admit, I think every physician can look back on their career and they'll remember a patient not because of some miraculous cure, but because they think there was something they could have done differently, something they could have done better, or something they did not do that they should have done. I think we all have that in our past, or most of us do, and it's how we learn. And so I think as he goes forward, my hope is that he will actually remember my sister so that his patients in the future will benefit. There were other physicians involved, physicians who were more mature, who I think should have known better. And I can't quite speak for them, what I would hope for them, because their motivations to me remain somewhat obscure. But for that young man, that is what I would hope, that he learned from this horrible thing and that his patients in the future will benefit.
And my final question, Sydney, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Well, there are two, if I may. The first is that a woman with stage 4 breast cancer, or for that matter, any patient with any kind of advanced cancer, can have other things wrong with them, things that are not cancer, things that are eminently treatable and even curable. And if we assume otherwise, certainly in the absence of proof, we do our patient a profound disservice. And second, arrogance has no place in medicine. Confidence, yes, confidence in your knowledge, your expertise, your ability, that is something we would all hope to have, and it's something that we need in order to function, but not arrogance. Because it was arrogance, I think, that allowed the physicians to not even consider that something could go wrong during a procedure in which they participated. And it was arrogance, I think, that allowed the young physician to stand at the foot of my sister's bed and simply say, she has stage 4 breast cancer, as though he knew enough about breast cancer to know that was the cause, when that was a disease totally outside the realm of his specialty. Arrogance does not belong in our profession, because arrogance can kill.
Sydney, thank you so much for sharing your story, time, and insight. And thanks again for being on the show.
Thank you, Dr. Poe.